Good afternoon and welcome to Leveraging Data for Policy Impact State Work on Prescription Drugs. My name is Johanna Butler and I'm the Director of Healthcare Costs at the National Academy for State Health Policy, or NAHDP. I'll be moderating today's webinar. Thank you all so much for joining. We're really excited to host today's discussion in partnership with our friends at the National Association of Health Data Organizations, or NAHDO. Today's webinar, as you know, will highlight how states are using prescription drug price transparency programs, as well as all payer claims databases to generate actionable insights that can shape policy decisions and improve affordability for consumers. I'm really pleased to be joined today by an outstanding group of speakers, and I think we can go ahead and pull up our agenda on the next slide. So today we will hear from Norm Thurston, Executive Director of the National Association of Health Data Organizations, who will provide some background on NAHDO, as well as discuss the important role of health data infrastructure in supporting state policymaking. We are also joined by Annelisa Steeber, who is the Pharmaceutical Economics Manager at the Minnesota Department of Health. Annelisa will share how Minnesota is leveraging data from its price transparency program, as well as its all-payer claims database to increase transparency into prescription drug pricing. And finally, we have Kirk Williamson, the Director of Affordability and Pricing at the Vermont Green Mountain Care Board, joining us to present findings from the state's Medicare Maximum Fair Price Pharmacy Analysis, which estimates the potential savings from extending Medicare negotiated prices more broadly across the state. So thank you in advance to all of our speakers for joining today. Just as far as some housekeeping throughout today's presentations, please feel free to submit your questions for the panel using the Q&A function at the bottom of your screen. We'll reserve some time at the end for audience discussion, so really excited to hear your reactions or questions for the group. And I will also just note that we will make the slides and a recording of this conversation available for participants on both the NAHDP and NAHDO websites after this webinar concludes. So you don't have to write everything down. We will share the resources afterwards. So with that, we can jump in with a quick introduction to the host organizations, NAHDP and NAHDO. So for those of you who might not be familiar, NAHDP is a national nonpartisan nonprofit organization that supports state officials across agencies and states as they develop and advance innovative health policy solutions. Our work is guided by an academy of diverse state officials, including my co-host for today, Norm Thurston. And NAHDP has worked on prescription drug pricing issues since 2016 and regularly convenes states with prescription drug price transparency programs. So now I will let Norm introduce NAHDO.
Thank you, Johanna. So I'm Norm Thurston. I'm the Executive Director of the National Association of Health Data Organizations and the Chair of the APCD Council. I just want to, for those who are not familiar with us, just tell you a little bit about what we do. The National Association of Health Data Organizations is a nonprofit association or a membership association, and we are dedicated to improving healthcare data collection and use. Our members are leaders across the country in hospital discharge data reporting system and all payer claims databases. The APCD Council is a program of NAHDO, and it is a learning collaborative of government, private, nonprofit, academic organizations, pretty much anybody who's interested, and it's focused on improving the development, deployment, and operation of all payer claims databases across the country.
Great. Thank you, Norm. So before we turn to our state speakers, we wanted to just first provide some level setting information and kind of explain why is transparency needed in prescription drug pricing. If you're joining our conversation today, you probably know the answer to this already, but just in case, wanted to give some background for people joining. One contributing factor to high drug costs and affordability challenges is the complexity and opaqueness of the drug supply chain, as displayed in this chart. As you can see, there are many different entities involved in both the movement of a product to get to the end user, a consumer, and the payment for prescription drugs. So to better understand net prices and gauge the impact of each supply chain entity on overall cost and affordability challenges, states are leveraging a variety of data from both APCDs that Norm mentioned, as well as drug price transparency programs to really gather all of the potential data and develop analysis to support and inform smart policy action. So we'll now just give a quick overview of those two data sources that states have leveraged. So first is prescription drug price transparency programs. This is a map from the NAHDO website and our transparency toolkit, which you can access on our website. At least 30 states, as you can see here, have enacted some form of prescription drug price transparency legislation, and they've been working on this for quite some time. We have the opportunity to regularly convene these states. All of their programs and statutes look a little bit different, but ultimately the goal is to collect actionable data to inform policy. And like I mentioned, each of these programs looks different and they vary in terms of which entities along the supply chain that are required to report price data or other information. You can see from this chart that PBMs are the entity that are most required to report across the different state programs, but I'll say kind of the more comprehensive programs that we see often collect data from multiple supply chain entities, including manufacturers and health plans, to try to put together kind of a holistic look at pricing and the factors that go into cost and price for prescription drugs. So with that, I will turn it to Norm to cover APCDs.
So I think there are some of you here are familiar with APCDs, but many are not. So what is an all-payer claims database? And here's the basic idea. An APCD is a large-scale database that collects claims and payment records from all of the payers that are available, whether that's commercial insurers, Medicaid, Medicare, third-party administrators, PBMs, wherever those data are available. They pull those together. And almost all of the APCDs that exist today are at the state level. So they cover the entire geography of a state, although there are some outlier cases where those are just at a regional level, so either sub-state or across multiple states. The practical value, the reason for doing this, and most of these are created by state statute or state government, is to give us unprecedented transparency into healthcare spending. We can also use that data to look at cost and quality variations across different populations, geographies, provider types, etc., and also develop performance metrics that will allow policymakers and systems to create evidence-based reform. So that could be at a hospital system level or at a state regulatory level. There are opportunities to use those performance metrics to drive improvement in both quality and cost across the systems that are measured. So what is available in claims data? So a medical claim or a pharmacy claim would be the basic unit of an all-payer claims database. They receive data in addition to those medical claims on the providers, like the list of contracted providers by health plan or different sort of variations on that. Enrollment history, so all of the people who are enrolled in that particular plan, we can see when they started enrollment, when the coverage ended, family members that are covered on the same policy, and different things like that. We have also recently seen some states add non-claims payments, so additional payments for hitting specific quality targets or rebates or other types of non-claims-based payments, and there are some other types of ancillary data that sometimes gets included. But the core of that is the medical or pharmacy claim. This data can be used to create a comprehensive, retrospective, and longitudinal episode of care. So for any one person, you can look and see what happens to them across provider types, across payer types, and across time. And I think that's the most important value of this, is that you can get those longitudinal episodes of care. So I just want to quickly tell you, in case you're not familiar, what is in a medical or pharmacy claim. Of course, you learn about who the patient is. You learn demographic information about them, such as their age, their gender, their sex, things like that might tell you something about them. And identity has an asterisk there because not all states collect and maintain things like name or address. Sometimes those things get suppressed in part of the analytic process. But if in those cases, usually there is some sort of an encrypted identifier so that we know that this person is this person. We may not know who they are, but at least we know that it's the same person across time. We also, on a claim, will see who was the provider, who performed the service, where the service was performed, and if there's an ID number associated with that provider, which most of the time there is, so that we can again see for that same provider all of the patients that they're seeing across geography, across time, etc. Claims usually have diagnosis codes. They usually have procedure and services codes, including service dates. And finally, what sets APCDs apart from other data sources are that you actually have payment data. As those of you who've worked with us before know that there's such a thing as a billed charge, which is rarely the amount that anybody pays. So we kind of discount that as not being all that useful. But all payer claims database data usually is getting actual payments. How much did the insurer pay for this? How much was the patient expected to pay for their copay or their deductible? And of course, when people have more than one insurance coverage, we need to know that it is in fact a coordinated benefit, so that we're not double counting it as two of the same thing, so that those payments get coordinated across the different payer types. So this is just a map that we like to refer to so that you can see how common are APCDs across the country. The most important part of this, of course, are those that are existing. Those are in the darkest blue. Those are existing, what we would consider state required or state mandated all payer claims databases. And then there are 4 existing voluntary efforts in Wisconsin, Missouri, Oklahoma, and South Carolina that are similar, but they are not state mandated. And so they operate in a similar way, have similar types of data, but operate under a different governance structure. So if you put together those dark blue ones with those 4 additional states, you'll see that these are pretty much across the country. They're across the political spectrum, and it's become the majority of states that have them now. So we are very interested in helping other states that might not have one, but might be interested. We have resources to help them understand what it takes to build one, what it would take to operationalize and implement them. And so we're happy to help. If you are from one of those states that is in no current activity or just in strong interest and need help, reach out to us. We're happy to help you figure out what the next steps are to make that happen for your state. And I think that concludes my part. Thank you, Johanna.
Great. Thank you, Norm. And I'll say from our legislative tracking, each session we see continued interest in APCDs and are always excited to leverage the tools and resources that NAHDO has. So with all of that level setting behind us, I'm excited to turn it to our first state speaker. Annelisa will now share more on Minnesota's exciting work. Annelisa.
Thank you. I'm Annelisa Steeber. I lead a team in Minnesota that focuses on prescription drugs and pricing. And before I kick it off further, I want to thank NAHDO and NAHDO for hosting this rich conversation. Really looking forward to hearing from you and what your questions are. So for me today, I'm going to give a little bit of an introduction to kind of Minnesota's prescription drug programs and some of the data that we have, but mostly focus on a handful of examples of ways in which we are using the APCD to enhance that prescription drug work. Next slide, please. All right, so my team is within the Health Economics Program, which sits further within the Minnesota Department of Health. We are a group that really leverages data and research and policy to bring all 3 of those together in multiple forms. And within the Health Economics Program, we have both our APCD team that manages it and does research with it, and then also my team, which does more prescription drug focused work. Next slide. So again, I probably don't need to say this, but the pharmaceutical market in the United States is incredibly complex, it is opaque, and it is dynamic, meaning it is fast moving. And states are increasingly taking on work within this policy sphere. Here, I'm just going to highlight a few of the initiatives in Minnesota. Like many other states, we have had recent legislation to try and learn about prices and the market, and also regulate it and try and help patients afford it. So these are not clean categories, but it gives a little bit of a flavor for some of the programs in Minnesota. So in that top bubble, transparency, Minnesota has the Prescription Drug Price Transparency Act, which was established in 2020. We also have a 340B covered entity report, which is from 2023. Both of those help us get data to the public on drug prices and some of the mechanics of the programs related to drug prices. In the kind of the regulation area, we license PBMs. That is since 2019. We also have rules around including low-cost drugs on health plan formularies. Medicaid has undertaken a number of PBM reforms in the state Medicaid program. And then in kind of the affordability bucket, we have recent caps on out-of-pocket payments. These are primarily for chronic diseases, including diabetes. And so making sure that those ongoing costs for many patients are capped out of pocket. And then the Prescription Drug Affordability Board, which there's a handful of states with these as well, with a focus on identifying certain drugs and the opportunity for an upper payment limit, which would cross over a little bit into kind of that regulation bucket. But altogether, and this is certainly not comprehensive, but altogether, this is to say the challenges of drug pricing and affordability are really complicated and require multifaceted approaches, and really to act in partnership. And so, what you see here are a number of entities across the state that try and tackle these issues. Next slide. Okay, so this just a brief introduction to our transparency work in the states. I'm going to talk a little bit about a subset of the larger transparency effort, which is known as drugs of substantial public interest. These are a powerful tool, especially combined with the APCD. So this is kind of a second iteration of the Transparency Act in the state in response to a number of limitations from the original act. There are 4 reporting entities. So if you think back to the earlier NAHDP slide about what kind of reporting entities are there, the ones in dark blue are the ones that are reporting to us under this initiative. So drug manufacturers, wholesalers, PBMs, and pharmacies, so that we can try and get that comprehensive look at what's going on in the supply chain. The data are fairly rich. It's prices, but also a lot of those transactional rebates, fees, clawbacks, all of those sorts of things across the supply chain to try and get a better handle on those cost drivers. And then the final kind of unique thing about it is the reporting driver is really a list of drugs identified by the Minnesota Department of Health. And so we are creating lists that are kind of customized to get at that question above, which is providing greater consumer awareness of the factors contributing to the cost of prescription drugs in the state. So with that, I'm going to turn to a handful of example projects that Minnesota has done related to drug pricing and the APCD. So here is just a little snippet from our 2026 legislative report. We looked at the drug classes and their gross spending for drugs that were required to report under the Transparency Act for price growth. So these are drugs that are on the market and their prices have been increasing at a relatively high rate, such that it triggers kind of a threshold that's set in statute. And this is, so of the drugs that are quickly increasing in price, how much are we spending on them? And we're grouping those by therapeutic class. So here you can see over time, the top 3 have really been persistent. You can see anti-inflammatory pain relievers, dermatologics, and anti-cancer drugs are amongst those drugs that are, one, expensive and we're spending a lot, and those prices are increasing at a rate that is pretty high compared to other drugs. Next slide. Another example is our work with the Minnesota Prescription Drug Affordability Board. So the Department of Health is charged with helping the PDAB identify drugs that meet certain statutory criteria. So these are criteria set by the legislature that they thought would be helpful for the PDAB to consider in their work. And so we take those statutory criteria and identify the drugs at the NDC level that meet the criteria. We use Metaspan for this, which is data set that we purchase a license for. It's similar to other data. Similar data set would be the first data bank. And that addresses a lot of them, but one of the criteria, the second criteria, are drugs that have a WAC or wholesale acquisition cost over $60,000 per year or course of treatment. So very, very expensive drugs. And the piece here is Metaspan would have a single point in time price. You purchase one, whatever the unit identified is, and it is a price and it is a point in time. But that is incomplete when you look at per calendar year or course of treatment. So this is where we turn to the APCD to help identify a lot of those drugs in that second bar there under number 2. Because, if you have a so-called maybe less expensive drug of say only $20,000, the actual WAC, but you need to have 4 treatments within a year, you're then well above that $60,000 threshold. And so this combining those and using the APCD to look at like patients' actual spending on these drugs helped us get that more comprehensive view of what patients are actually having to pay for a drug in a year per the statutory requirement. Another project, this one is a recent publication out of the Health Economics program where we looked at rare diseases and the potential for using gene therapy. So this, I think, is really interesting because it uses the APCD not for kind of a retrospective look, but actually thinking forward and using it to forecast and do some health system planning. This is work that we did in partnership with the Rare Disease Council. And really the kind of core question is, how does the state prepare for and think about gene therapies for populations with rare diseases for which the gene therapy can be life-changing, really increase their quality of life, maybe one of few treatment options, but there's significant access and affordability challenges. On the gene therapy side, it is a rapidly evolving, shifting market, high cost, often in the millions of dollars for a single treatment. The regulatory environment is shifting, and there's, for the patients, complex care and a lot of coordination related to that. So how does the state, in this case, the state of Minnesota, think about that? And here, use the APCD to identify people, like the prevalence of certain rare diseases. In this case, the study looked at 9 rare diseases. And for those 9, identified that there's about 2,500 Minnesotans living with those diseases. And then further took another look using claims data to get a best estimate about who might be eligible for a gene therapy. This is certainly not a perfect analysis. There's a lot of assumptions that need to be made, and there's only so much data that you can see in that claims data, but it still is the best information available, and it is important for planning, for making sure there's appropriate capacity and insurance coverage. And I think this sort of analysis helps center some of those conversations when there are so many unknowns, so much known need, but not necessarily the data to think about it. And this helps start that conversation. And then over time, the APCD is further going to be leveraged to help identify, what actual spending is, actual use of gene therapies, that sort of thing. So really interesting study here. Again, not the full market, not complete data, but again, it does a really great job, I think, of centering that conversation at this point in time. Next slide, please. Okay. This is the last example I have. Like I had mentioned in our price transparency work, MDH identifies a list of drugs that are of interest to which we collect data on. The most recent list that we published this spring was the first 10 drugs for the Medicare Drug Price Negotiation Program. I'm not going to go too deep into this because I know Kirk is going to talk about this in a little bit, but we wanted to get a handle on what the prevalence, like what do we spend on these drugs currently in Minnesota? And so we looked at 2024 data for this group of 10 drugs and found that the state currently, well, in 2024 spent about $1.5 billion on these drugs, which is an average of over 1,300 per claim for these drugs. So high utilization, high cost drugs. And then further, to kind of think about the importance of these drugs in Minnesota and why we want to collect data on them under this program, looked at what if the Medicare negotiated prices were applied more broadly than Medicare. This is not the program, but just kind of to get an understanding of the impact broadly, and found that there could be more than $1 billion in gross healthcare expenditure savings, and then broke that down by different plan types. But the big caveat here is these are only gross expenditures. We don't have the view at this point to include the rebates, which would reduce those savings because it would be assuming that everyone is paying that full price currently, which we know they're not. We know that there's exceptions, like we can't get quite yet at that net spending. And so this is a big caveat to some of this work, but still I think an important starting point, again, is kind of a centering place to tell that richer data story by bringing in the prescription drug pricing data, the APCD data. And for this one, when we do collect data on these drugs, we will be able to get a better picture on those net prices because that drugs of substantial public interest data includes rebate data. Next slide, please. Okay, so to round it out, all of these projects are made possible by working in partnership across the state with other entities and by connecting data sets, particularly the drug pricing data with the APCD data. But I would be remiss to say that this is a full picture of the market. We know that there are still a lot of areas that we still can't see, can't really fully understand. And so there's a few of those here. Some of them we're making progress on, others are still areas to explore further. So on the kind of really big picture market structure and financial flow perspective, like I said, rebates and net prices, we're making progress, but still more work to do there. We know PBMs are shifting their business models beyond rebates and spread pricing, and so trying to explore how we get better understanding in that sphere. Vertical integration and horizontal consolidation are always a consideration in this market. And then briefly, some emerging policy questions. There's a lot related to 340B that we're just starting to understand related to prescribing patterns, patient impact, manufacturer pricing, and more. Patient assistant programs, specialty pharmacy, pharmacy network, and some patient access are just a couple others that I want to say that we still don't have full eyes and understanding of. So that would be areas that we can continue to grow. And with that, thank you for your time and attention, and I pass it back to you, Johanna.
Thank you so much, Annelisa. Really helpful and interesting overview. Next, we will turn it to Kirk Williamson to hear about Vermont's work on Medicare maximum fair price pharmacy analysis. So a great segue from Annelisa's mention of it.
Yes, thank you, Johanna, and it's lovely to be here. Hi, everybody, I'm Kirk Williamson. I am the Director of Affordability and Pricing at the Green Mountain Care Board. Always great to hear the amazing work in Minnesota, and hats off to Annelisa and her team for everything they've got going on. I always learn so much, and thank you to NAHDO and NAHDO for the invitation to present today. We can go to the next slide, please. For those of you who may be unfamiliar, the Green Mountain Care Board, we are an independent 5-member board that regulates major areas of Vermont's healthcare system. We really do this in service to the public interest with a focus on transparency and accountability and a commitment to evidence-based regulation. So we can go to the next slide, please. So Act 134 of 2024, it tasked the Green Mountain Care Board with developing a framework and methodology for regulating prescription drug costs. We partnered with On Point Health Data and Horvath Health Policy to explore regulatory and non-regulatory approaches to prescription drug cost control and assess the potential impacts. We produced a few of analytic products, which you can see here on the screen, but I'm here to talk about our maximum fair price analysis, which evaluated the potential savings from adopting a reference-based pricing approach using the Medicare maximum fair prices from CMS. All of our analytic dashboards are available on our website, including the reports you see here on the screen. And the analytic dashboards are also accompanied by methods documentation. Next slide, please. So very briefly, the Inflation Reduction Act of 2022, it did a whole host of things, and then it did a lot of things with prescription drugs, but notably it authorized the federal government to negotiate prices with pharmaceutical manufacturers for high-cost, single-source drugs without generic or biosimilar competition for people with Medicare. And to give you a sense of the size of the program, total Medicare spending on all drugs for the 40 drug products that have been selected to date, they accounted for more than 1/3 of total Medicare spending on all drugs covered under Part B and Part D in 2024, or about $125 billion out of $350 billion, not accounting for rebates in Part D, which is roughly equal to CBO's initial estimate of total program savings over a 10-year budget window. So the savings have grown quite considerably since the program started just a couple years ago. Next slide, please. So for our MFP analysis, at the Care Board, we were really interested in understanding the potential impact, similar to Minnesota, in extending the MFP as an upper payment limit for the relevant drugs in Vermont to all populations, notably the commercial market and all employers, not just the Medicare population. And so the value of using the MFP is that it offers a publicly available price benchmark in a market that is notoriously opaque, particularly for net prices of branded drugs. So to do this analysis, we relied on VCures, which is Vermont's all-payer claims database. We have about 60% of the commercial market, so we were able to impute self-insured claims, and you can read more about that in our methods documentation. And then we also used the publicly available pricing list for the 2026 and 2027 Medicare negotiated prices. And I'll note we did not have access to Medicaid or commercial net price data. This analysis really relied on the allowed amounts on claims. So that included the plan paid and the patient paid amount, which is to say that these values really represent the amount paid that went out the door to manufacturers before any rebates or price concessions were passed back. So next slide, please. So to give you a sense of the totality of spending across Medicaid and commercial in 2024, Vermont spent about $635.1 million on prescription drugs in retail settings, so those drugs that were reimbursed under the pharmacy benefit. For the first 25 selected drugs, those drugs have been on the market anywhere from 9 to 28 years without competition, 28 years in the case of Enbrel. We found that $150 million was spent across Medicaid and commercial on the 25 selected drugs in 2024. And because we didn't have access to net prices, particularly for Medicaid, which has its own host of very special prescription drug financing rules, I'm just going to focus on the commercial market for the rest of the presentation. But I think it's really important to understand that now with the 25 drugs that have been selected for negotiation with publicly available negotiated prices, in Vermont, we spend about $1 in every $5 on our prescription drugs just on those 25 now negotiated drugs. But we don't have access in the commercial market, at least not yet. Next slide, please. So between 2018 and 2024, spending on MFP drugs more than doubled from 45 million to about 100 million in the commercial market. These drugs, they represented about 22% of total pharmacy spend in 2024, despite accounting for just 84,000 claims. So about 3% of volume. And so it really drives home the fact that we spend on brands, but we use generics. Next slide, please. We found that the savings are highly concentrated among 10 drugs, or the 10 drugs you see here on the screen, which account for about 90% of the total potential savings. The remaining 15 drugs that have been negotiated together contribute just under 10% of total savings. And so 95% of MFP related spending, it really does, at least in Vermont, it comes from chronic disease medications rather than acute or episodic treatment. And so from a budget impact perspective, savings realized in 2024, those should recur and would be likely to grow in subsequent years for most of this spending. And then from a policy perspective, an approach that initially focused its implementation efforts on just two therapeutic classes. So if we took GLP-1s and anti-cancer drugs, that would capture actually a majority of the savings among those drugs that have been negotiated thus far. And this could help target state efforts towards the greatest ROI without having to go through and do all 25, but you could capture a majority of the savings on just two therapeutic classes thus far. Those drugs being Ozempic, Rybelsus, and Wegovy. Those three drugs share one active ingredient, and then Stelara and Enbrel. And GLP-1s, they did make up about a third of MFP-related spending. Next slide, please. So moving on to discounts and savings, we were able to find Vermont could have saved an estimated $90 million, or about 14% in 2024, when comparing what Vermont payers actually paid to the MFP negotiated prices for 2026 and 2027. The highest percentage discounts really cluster among older diabetes drugs like Janumet, Tradjenta, and Januvia. But more broadly, we found that the drivers of negotiated savings, so not the drivers of necessarily the highest percentage discounts, are really a function of the absolute price level and the utilization volume. So you can think of it in two different buckets. The first around specialty drugs, those with very high unit prices, but perhaps much lower volume. Products like Stelara and Pomalyst, they generate very large absolute savings, almost entirely from price reductions as composed to volume. And then there are other products that have maybe more moderate unit prices, but are very high volume, such as Ozempic, Wegovy, Rybelsus, or even Eliquis. They generate quite large aggregate savings, though their per fill savings are modest when you compare those to specialty drugs because of their high volumes. And this matters because the volume channel for this related savings will likely grow faster than even the price channel for existing drugs, meaning savings are cumulative. And it also means that for future negotiation cycles that capture additional high volume chronic disease drugs, that'll have an outsized fiscal impact even with more modest per unit discounts. Next slide, please. And to summarize some of our key findings from this analysis, MFP selected drugs, they account for significant pharmacy spending in Vermont, about 30% of total pharmacy spending, or $150 million in 2024. GLP-1s and specialty drugs, we found those accounted for a majority of the spending among the 25 that have been negotiated. And then MFP negotiated prices, they could yield substantial savings, ranging anywhere between 25% to 85% for these drugs. Next slide, please. And so what comes next? We're continuing to build the evidence base and increase transparency. We do plan to annually evaluate an MFP-related savings as newly selected drugs have published negotiated prices. And then we will continue to monitor the status of litigation and state implementation of upper payment limits from PDABs that are now moving forward with upper payment limits, notably in Colorado and Maryland, to continue informing some of the legislative discussions we have here in Vermont. So next slide, please. I think that wraps it up. Thank you so much, and I look forward to the discussion.
Great. Thank you so much, Kirk. Really appreciate it. It's exciting to hear about kind of similar analysis in Minnesota and Vermont to leverage those Medicare negotiated prices. I will just flag that NAHP does have model legislation for states interested in a similar approach of how to leverage those negotiated prices as a UPL for the broader market. So check out our website and stay tuned in our newsletter for more updates there. I think we now have time for audience questions. We've had a lot of feedback in the Q&A feature, but for participants in the audience, please feel free to continue sending things through the Q&A function. So I think at this time we can go ahead and pull down the slides, and I invite all of our speakers to turn on their video and join us for some questions. The first question is for Annelisa and Kirk. You both sit in offices or agencies with although not perfect, fairly robust data and analytic capabilities. And I think there are some people in the audience who are maybe a little bit jealous of kind of that level of data access, analysis, a focus on things like economics and spending time on this. Curious if you could share a little bit about how your offices or your work was established and how you've kind of developed and strengthened data capabilities in your states over time. Big question.
I guess I can go first. So at the Care Board, we do house the APCD. We are also integrating VUDs, which is our Vermont hospital discharge data, and that's much newer, a bit more longer term. So we are always increasing our analytic capacity, and I think Annelisa would probably share this. There's always so much more we wish we could do. These are very large and complex data sets. We could not do this without our partners, particularly at On Point Health Data. We have a lot of academic partners that we will also go to help with our analytic capacity or help to shape the way in which we are approaching these types of new exploratory analyses. But I think, it's about building also internal capacity. We have a very strong data team and data analytics team. It's small but growing, and I think that is institutional knowledge that can't be taken for granted. And we really pride ourselves on evidence-based, data-driven policy making here in Vermont. And so for folks to draw on this type of rich economic data and our claims data, to pair that with a lot of policy options and trade-offs, it just really helps to make a more informative discussion. And it has been painstaking over time, but we were one of the earliest states to adopt an APCD, and we're always happy to talk to other states about how they're leveraging it, and we're always learning new ways in which states are going about maybe using AI or leveraging new tools to automate a lot of the claims processing. So I think there's still more to learn, and we really value these discussions with folks like at NAHP and NAHDO to facilitate that bi-directional conversation between states on how we can do this better. But I'll turn it back over to Annelisa.
Yeah. Minnesota, I think, similarly has a rich history of having strong health data. I mean, I really credit our legislators and our leaders for having that kind of foresight to continue to support this kind of work. I mean, the value of the APCD in Minnesota, I think, is really self-evident in how it supports so much work across the state. I think also, stepping into the prescription drug space, not an easy area at this point in time to really dive into. And so having that continued support from the legislators and the legislature and from leaders to continue to invest is really incredible. And I hope that, we do our best to take that data, connect it as best we can, really leverage it, and, provide value to the people, provide these insights, the whether it's a one page or a report or dashboards or all of those sorts of things to get a handle on this just ridiculously complex system. It feels sometimes inadequate, but it really is important. And like Kirk said, there's always so much more to do. There's so much more potential to collaborate across the state with our partners, connect the data. We're always have projects going to try and do that a little bit better.
Really helpful. And Norm, I'd also welcome your perspective on this question, especially as someone who has such a deep understanding of legislators' thinking of how you tell the story of why this sort of work is important. There are some questions from states where they don't have an APCD and there might not be interest. Like, how do you start to build that interest and momentum? Oh, and you're muted, Norm.
You have discovered my secret superpower, which is talking while on mute. So, so I think from a political perspective, and I'm just going to maybe speak on that, just go a little bit political here. If you're trying to generate interest in a state all-payer claims base, you have to be able to talk to your legislature about something that rings important to them, not just true. It has to actually ring important to them. And for most legislatures, the issue of rising healthcare costs is really high on that list. Businesses care about it because that's cutting into their profit margins. People care about it because they have rising out of pocket caps or copays and deductibles. So it really does get to the legislature saying, look, we are concerned about rising healthcare costs, and you can't create a program to do anything about that without understanding the nature of the problem. And so when it comes to pharmacy, absolutely this applies. We don't know why it's going up. Because we just don't have the data. And really, there are some quality opportunities as well. But honestly, I think from a political perspective, it's mostly going to appeal to them to talk about money, because every state struggles with budget. And another kind of subcategory of that is that state legislatures they are the largest payer of healthcare in their states because they've got state employees, they've got higher ed university employees, and to the extent that different states have some responsibility for city, police, fire, county, et cetera, there may be those as well. But by the time you add up higher ed and state employees, you're already talking about a massive enterprise in almost every state in the country. So it's about budgets, it's about cost, it's about understanding it. And then, of course, I think that the real kicker there is that policy should be evidence-based. And I know that's a NAHDP priority as well, that if we're going to do policy, we should have evidence. And so you've got to invest in the data programs and the evidence programs to make this work.
Really helpful. Thanks for that, Norm. We're getting a couple of questions, Annelisa, on the lists that Minnesota develops and tracking high spend drugs and also like growth over time. Some interest in understanding like how much do those change or vary year to year versus remain like kind of the same drugs are there and you've noticed they're consistent candidates on that list. And then also if you have a sense on like growth over time, how Minnesota compares to national trends or trends in other states, if you're doing any of that sort of comparison.
Yep. So the drugs of substantial public interest portion of our Transparency Act is relatively new. So we are still kind of getting it underway. And really, I think it's still finding what its potential can be. We have definitely considered that kind of like consistency over time piece. Like the legislation is unique in that it can be somewhat dynamic and responsive to the market and be pretty flexible, understanding that there are multiple markets in the prescription drug market. And so not trying to narrow it down. And there's also multiple criteria. There's so many ways to think about this and what's important in the affordability space, whether it's costing the state money, individuals, small populations with very high costs or large populations with moderately high costs. And so we have definitely considered coming back to lists over time to kind of get that piece. The part of the reason we did the Medicare list this spring is because the actual data collection period is 2025. So we are going to get that pre-MFP price period like snapshot, if you will, to kind of get a handle on it before those prices go into effect in when they went into effect in 2026. So thinking about that strategically, definitely. And so trying to strike that balance between being able to be very responsive and kind of look at those different segments of the market, and then over time come back to some lists. In terms of repetition, so insulin is one of the lists on that first 10, and we had already posted a full insulin list. So trying to get a handle on insulin. Minnesota has had a lot of legislation on insulin. We think it would be a really important topic for the state, but we left off insulin from the actual data collection and reporting on that on our Medicare list to kind of avoid that duplication at a very similar point in time, just because we would have had really recent data anyways. So one way that we're kind of navigating how we are strategic about those lists and responding to Minnesota's needs there. In terms of Minnesota versus national trends, I'm not in this moment going to speculate about that. Certainly could. I mean, a lot of what we see is really similar, across the whole country. It's a national market. But I'm sure that there are areas where Minnesota is higher or lower, but I wouldn't dare speculate in this moment.
Helpful. Thanks for that. And we're also getting some questions on kind of what data elements would be on your wish list. Kirk, Annelisa, Norm, feel free to weigh in on this as well. Like, what do you feel like you're still missing information on? I think rebates has come up quite a bit of like a real challenging gap. And then also some questions on recognizing that there are those gaps. How do you think about appropriately caveating your analysis in your reports to still put out kind of what you do know while being kind of honest and transparent about what we're missing?
Yeah, maybe I can just talk about that last chunk first, and
Hmm.
Annalise and Kirk can also comment on this. When I took statistics in college, like forever and ever ago, we talk about the reason why you need statistics is because you never have all the data. But there's this entire field that has been developed, which are now called, data science or whatever you want to call it, but around statistics, to be able to make inferences about a population when you only have a sample of the data. And the reality is and I think Kirk mentioned this in his thing, and Annalisa, I knows this as well, that nobody is ever going to have 100% of everything. And so you can't do that, which is why statistical analysis exists, is to help you do that. We also talked in our class about things like 3% samples and 5% samples, and how you can really do statistics if you only have 3% of the data or 5% of the data. I will let them tell you their numbers are a lot higher than 3 or 5%. So the statistics gets a lot more accurate with those bigger numbers. And I think that's the biggest part for us, is to sell people on the understanding that you don't have to have everything to learn from data, because statistics is your friend. The analytics tools that we have in modern data science can make population inferences reasonable and very precise for the most part. So that's my introduction and my little soapbox on that issue, and I'd be happy to listen to what they have to say from their perspectives as well.
Yeah, I mean, no data set is complete and no data set is perfect. But I think it is being just very clear about what the data can and cannot say. And, it can go this far out on the limb, but not further, if you will. And it's still, and being clear about how to use it, I think, is also part of our job, and how what it can say and can't, which is really similar, but that kind of like that data-driven policy is so important, and where it really, I think, becomes so powerful, because, you can pick apart any data set, but that doesn't mean it's not valuable or helpful or informative in how we think about policy and at the state level. In terms of data we would wish for, I mean, it's a long list. But I think one of the things we are increasingly just kind of running up against is partially kind of like corporate structure, and kind of how a lot of the pieces in the market fit together, and how all of the organizations fit together, subsidiaries, that sort of thing. And then honestly, a lot of qualitative data in terms of like contracting. A lot of that's proprietary, you can't get at, but it really has a big impact on how the market works and like who has negotiating power and who and how the different entities relate to one another. And kind of how that has a huge impact on prices and who the players are in the market and how they can act and to what degree and all of those sorts of things. So that might be an area that I might put at the top of my list.
Yeah, and I jotted down contracts as well. I would love to see into the rebate agreements and any rebate traps. So rebate agreements that are conditioned on more than one product from a manufacturer and how those dynamics might play out in the claims data. I would like to know, the GPO pricing from hospitals. That would be great to know. I think when it comes to our ABCD, I noted we capture about 60% of the commercial market. So if we were able to somehow get that self-insured claims data, I think we, like Norm, we're trying to expand and grow larger, but we have figured out some methods to impute self-insured data, but we would love to partner with small employers to get that type of pricing data. I think we would love to have more granularity into net price data, both commercial and for Medicaid. I think even if we had that, I think there would be limitations on what we could put out because there are all sorts of privacy and confidential considerations on net price data itself. And I think we would also be limited in what we could publish. So it cuts both ways. And I think ultimately it's about not letting the perfect be the enemy of the good. This is it's a way for us to all speak to actual claims data, what we're seeing in the data. It's unbiased. We are an independent entity. We have rigorous partners that we worked with. And I think it's a tool to start a lot of conversations to go to payers and say, this may not be perfect. You may be getting lower net prices than what we can see in the data. What is your discount? And how does that measure up against what we're seeing using MFP negotiated prices? Certainly there are caveats and limitations, and there will always be caveats and limitations. But directionally, it's pointing going a certain way. And I think that is so instructive for policymaking generally.
Great. Thank you. I think that is probably a great place to leave it with the laundry wish list. I know we will also probably see new data shared with at least plans and Medicare as part of recent federal action that was enacted in February of this year, but not quite sure yet how that translates to state level transparency. So I think there's a lot more to be done in this space. So with that, I just want to thank our wonderful panel again for joining us and for our co-hosts at NAHDO for this great conversation. And thank you to everyone who joined us in the audience. You will receive a short feedback form via email. Please feel free to share your thoughts, any unanswered questions. And I know we had some requests to connect with people on the panel or the NASHP team come up in the Q&A. So please feel free to also submit that in your survey and feedback form. So thank you so much again for joining NASHP and NAHDO for this important conversation, and have a great rest of your week.